Welcome everybody to today's panel on radical care work, in which our panelists have been invited to reflect upon and share their work on transforming the caring crisis that has been shaping up over the decades and particularly heightened by the COVID-19 pandemic. This session is part of the Care Work Cluster series within the Rappaport Center's Pop-Up Institute, Beyond the Future of Work, which goes through June 11th. A couple of quick notes as we get started. We made this a Zoom meeting as opposed to webinar so that our presenters can see the audience during the Q&A. For now though, if you would like, you're welcome to turn off your cameras and please take a minute to just ensure that your mics are muted. If you would like to take a moment to add your preferred pronouns to your name, you may do so now, but that's totally up to you. During the conversation that we're having, you should feel absolutely free to type any general comments that you have to everyone in the chat. But you are also welcome to send any questions that you have in particular directly to myself, the moderator. If you're watching from YouTube, you may enter your questions in the YouTube chat and our student team member will pass them along to me. My name is Hi'ile Julia Kawehipua Kaho'opulani Hobart. I'm a Kanaka Maoli and assistant professor in the anthropology department at UT Austin. I'm the co-editor also of a special issue of the journal Social Text on the topic of radical care, which came out in March 2020. And I'll speak for just a couple of minutes on that project at the end of our panel as a way of kind of bridging into the Q&A. So in preparation for the event, we posed to the panelists a few framing questions. The first set of questions entails, how do you define radical care work? What are the forms of care work that you see in your area? And what might be some of the barriers to effective caring? And the second set of questions entails, how do you imagine the future of radical caring labor? And what do you think it might take to change these structures that sometimes prevent effective caring? I'm going to introduce each of our panelists ahead of their prepared remarks, which should be about 5 to 8 minutes each. And then we'll follow that by opening up to a general discussion amongst our panel and participants in the audience. And I'll introduce each person in turn. Our first speaker is Ashleigh Hamilton, who's a community organizer at Communities of Color United for Racial Justice. So I'll mute myself and I'll hand it over to you, Ashleigh.
Hello all, thank you for inviting me today. As you mentioned, my name is Ashleigh Hamilton. I'm a community organizer with CCU. First and foremost, I am an African-American female, a single mother of 2, East Austinite, born and raised. I'm coming to you today to talk about Black maternal health and why it's important to me. To me, Black maternal health is living and being able to be alive and be present with my baby, or experience an at-home birth, being given the opportunity to have a choice to have my baby in the hospital or not. Back in 2016, I had my son. At that time, I was forced into an emergency C-section. At that point, I had already been released from the hospital 5 times and sent back and actually driven myself to the hospital the day that I actually had him, all because my doctor didn't believe that I was in pain, didn't believe that I was experiencing contractions, didn't believe that I was actually going in labor. I had been turned away 4 times prior to having my son, again on the 5th time. Something that I always revisit is the pain levels I had to experience during my care at the hospital. It's a constant battle of me trying to convince folks that I need help or that I need assistance, and making them realize that I truly, in fact, deserve this care that I'm here and I'm supposed to be receiving. I didn't receive that. To me, that's a lack in the structure that was set up that was quote unquote supposed to protect us. It then makes me not trust that system, what we call the monster in our eyes, right? I think about all of the times that these institutions, i.e. police departments, hospitals, education systems are set up supposed to help us. However, when it comes down to Black and brown folks, they tend to leave us out. They tend to not show up for us. And it's not a 10, they don't. Those systems aren't built for us at all. As I work and I try and think of what reimagining public safety means to me and how we can change that in these spaces, first, I would always want to say, thank you guys for inviting us into this space and valuing our opinion. It needs to be more Black and brown folks. But not to mention, when we go to our doctor's offices, we want to be able to see doctors that look like us, or doctors that can relate to our experiences, doctors that aren't second guessing what I'm saying. I'm not here to seek out drugs. Or furthermore, treat me like I'm your white patient who is being given all of these different options. Oh, here's a home birth, here's a doula. My first time hearing about a doula was when I joined Black Mamas Community ATX. And again, 2016, when I was experiencing postpartum depression, something that's not talked about in the Black and brown community. Had I been given those opportunities to discuss that, or even just given other options, my outcomes might have been different. I want to be able to live to enjoy my children just as much as my sister does, my aunt, my mom, their cousins. I want it to be that when we show up, we're afforded those same opportunities that other people get without question. It shouldn't be that we have to go above and beyond and ask for special care just to be able to make it out alive. What I need from you guys today is to sign this promise that CCU and I have all been a part of and working on, that talks about that reimagining public safety and what that looks like. It starts with you and I. It starts with all the little people at the bottom. When we talk about what we want it to be different, how it can be different, here's how. Standing up and just encouraging in these spaces that more Black and brown people are present for the people that you guys, and I'm saying you in a very broad term, but doctors and police are working with. If you don't know how to work with us, or you aren't necessarily catering to our culture of life, then of course things are going to be different. But if you all take the time to read over that pledge and take the initiative to sign it, that lets me know that you stand only not with me, but again, my family that looks like me, others in the community that don't have a voice. Help us to be able to show up and change this radical care, even that I have lost faith in. Even working in the medical field, I don't see people that look like me. The more and more that we show up, the more and more that we have these conversations, the more and more opportunities begin to present themselves. And it's not that we just deserve a chance, but we deserve those same opportunities. We deserve to have people that look like us, and we deserve to be in these same spaces. So I thank you guys for having me today.
Thank you, Ashleigh, for speaking so powerfully. Our next speaker is Vrinda Marwah, who is a PhD candidate in sociology at the University of Texas at Austin.
Thank you. Thank you everyone for coming to this panel, and thank you panelists and organizers for having me. So because this panel is called Radical Care, I was prompted to go back to an essay that was written by Sharmila Rudrappa, actually, who's here, in 2004, where she looks at these South Asian American women's shelters and calls what they do there radical care, because she sees the caregivers as serving sort of individual women and even, this larger issue of gender justice. But she argues that even though what they're doing is radical care, there are inherent contradictions and it doesn't always meet its goal. So today I want to just sort of reflect on this idea of inherent contradictions in radical care. And I want to apply it to the women who are at the center of my research. I am doing an ethnography of women who are community health workers in India, and they're called Ashas. So who are the Ashas? I mean, there are so many important things that I can say about them. But most importantly, Ashas number about 1 million. They're the largest all-women workforce of community health workers anywhere in the world. And they've been appointed all over rural India and also in some informal urban settlements. They've been appointed since about 2007. And even though they were originally tasked with maternal and child health services, connecting their communities to these services from the government, what has happened is since their role has just sort of grown and grown and grown. So Ashas today are tasked with, I mean, you name it, cancer, tuberculosis, malaria, mental health, non-communicable disease surveys, like literally they've become like sort of foot soldiers of the Indian public health system, because they're the only workers in the system who are going door to door and who know a lot about the communities that they're from. With COVID also, these community health workers are at the front lines. So what they've been doing is they've been going again, door to door, conducting surveys, figuring out, suspected COVID cases, monitoring oxygen levels, body temperature, referring patients to quarantine centers, supplying medicines to the ones who are not going to the centers but quarantining at home, et cetera, right? So, as always, the job of the ASHA just sort of grows and grows and grows. But with COVID, we've all been reflecting on this, on essential workers, this term, right, essential workers. And this is where the contradiction that I began with speaking about, that sort of comes up for me, because ASHAs are essential, but ASHAs are not workers. So here's the catch, right? ASHAs might be working 6 hours, 8 hours a day. They might be working several days at a stretch, but technically they are volunteers. They were recruited by the Indian government, even at this monumental scale, not as employees, not as staff. They're categorized as volunteers. That means they don't get salaries. What they receive is an incentive. And the incentive is, say, per task that they complete or per patient that they bring in, right? So, and how is this incentive sort of calculated? At the end of the month, the ASHA will sit with her supervisor. They'll go over all her tasks for that month, and they'll total, the money from those tasks, and that's her monthly wage, okay? And this figure per month comes to, it's very different between states in India, but it comes to anywhere between $27 for the month to $135. That's the range. That's how much this health worker gets for a month of work, right? Now, what's happened with COVID is a lot of the routine work has stopped. So a lot of the routine incentives have dipped, but COVID duty is so long, ASHAs are working such long hours that they can't do other, say, side hustles or odd jobs that they may have been doing earlier to supplement their income. And in lieu of all of this, the government of India has started giving them a COVID incentive per month. And this incentive is about $15 per month, all right? Now, you can argue that like low wages are low wages, right? Does it matter very much if the wages are in the form of incentives or in the form of salaries? I actually find in my work that it matters very, very much that wages are in the form of incentives, because incentives push down wages. I find in my work that incentives create a big mismatch between the work that ASHAs do and the pay that they get. So for a lot of the work that they do, the incentives, they just don't exist. And even when the incentive exists, these incentives are not always paid out, and they're not always paid out on time. The other thing I find very important to the everyday sort of work of ASHAs is that the health department can manipulate incentives. So either by withholding or threatening to withhold incentives, the health department gets ASHAs to do a lot more work than they're supposed to do, right? And it gets them to do work that's constantly sort of outside of their purview or their jurisdiction or whatever. The other thing I find is that any claims that ASHAs try to make as workers are very easily dismissed using this sort of gendered discourse of service. You're not staff, you're only volunteers, and you're here to serve, right? I mean, you might ask, who is volunteering for 8 hours a day? Well, I can tell you, not men, all right? I'm from the discipline of sociology, and sociology is, is particularly fond of sort of comparative work. And when I set out to study women community health workers, I was constantly told by my committee, maybe you can also study a male workforce that's also sort of doing voluntary work and that's paid, so abysmally. And I would have included that comparison, except it doesn't exist. There is no such cadre of all male volunteers on the ground who are working this much for such little money. So this is an extremely gendered form of volunteerism that we're seeing in India. And I just want to sort of say that this is another contradiction that I feel like we need to be attentive to, especially when we think about like the future of care, right? That what's happening is with migration, with the nuclearization of families, with women entering the labor force, with pandemics like COVID, the paid care workforce is growing, and it's growing around the world in rich countries and poor countries. But in the case of ASHAs, what I find is that there are new ways in which the devaluation of paid care work is being institutionalized. So by appointing ASHAs as incentivized volunteers, we are coming up with a new way of the state itself devaluing this work, right? And I also want to say that the devaluation of care is not something that's unique to ASHAs. In fact, in India, poor women are being hired across welfare schemes, like schemes for the preparation of meals for children in schools or for childcare schemes. And feminist economists have called this, the formal creation of informality, because this is informal work that's being created by the state. So the state is sidestepping its own labor obligations in recruiting these workers and not giving them any rights as workers. I also want to say that the devaluation of care is not unique to India. All around the world, gender and development scholars have been prompted to call out a trend that they've termed the feminization of obligation, because they're saying what's happening is women are being made to work for development rather than development enabling women to secure better work. So again, like as I finish, I want to say, I'm just sort of, my work just makes me very alive to the sort of contradictions in terms like radical care and to sort of the material reality of people who are in a lot of these paid care roles. So I think any vision for the future of care should aim very, very strongly to bring the state back in, because there are investments in public services, investments in public service workers that only the state can make. And there is a regulation of private services in tandem that needs to happen, which also only the state is in a position to do. So to hold the state more and more accountable, and hopefully to, with pressure from below and above, to sort of responsibilize the state is, I think, a very important part of where the future needs to be. Thank you.
Thank you, Vrinda, for that really crucial analysis. Our next speaker is Deborah Para-Medina, who's a professor of Mexican American and Latino Studies and director of the Latino Research Institute at the University of Texas.
Hi, everyone. Thanks for inviting me. So I'm Deborah Para-Medina, and I'm a public health epidemiologist by training, and my work focuses on health disparities in chronic disease. And in my research, I work in partnership with affected communities that experience inequities in health. And these are health outcomes that are avoidable, unnecessary, or unjust. And together with these communities, we try to identify and implement solutions. So I was drawn to the field of public health because it is grounded in social justice and the idea that everyone deserves equal rights and opportunities, including, the right to good health. And so during my work, I engage with all kinds of care workers, right? A lot of people, when you're in public health and in healthcare, community wellness and social services, you are involved with different types of people who take on different types of caring roles. And they bring, gifts of the head, the heart, and the hands. So, but my research specifically focuses on US Latino populations. I've worked with Latino populations primarily in the US. in both urban and rural areas, on the border. I've worked with immigrant and US born and financially disadvantaged primarily. Also in a variety of settings, so clinics, schools, community-based organizations, other kinds of community rec centers, community resources. And primarily, I focus on women and girls and family-centered approaches. So one of the primary way I come into care work is because the work that I do often works with promotoras de salud, which is kind of like an ASHA, but in the Latino community it's called a promotora. Also lay health advisors, or known as community health workers. And so since the early 90s, I've been working with promotoras in all kinds of regions of the country, from California to South Carolina, and now in South Texas. And I've worked with promotoras in a variety of ways. So from volunteers to incentivized workers to full-time certified employees. And I think it has changed over time. So some of the earlier experiences in the 90s, they were primarily volunteer and incentivized. And then since coming to Texas, where they actually have a certification process, you see them more in a formal professional role. But when I was in South Carolina, where we had a large immigrant population and a large proportion undocumented, we had to use a lot of the informal sector for organizing and working with that community. So, community health workers can work in a variety of roles. They can be, linking communities to clinical services. They provide outreach and education, navigation support, or advocate for patients, patient advocacy, among other things. And so one of the things about community health workers is ideally they're supposed to be from the population they serve, right? So that they work, live, play in the same communities with the people that they're doing outreach with, serving, and that sort of thing. And so they actually reflect the same kind of social demographic characteristics and potential risks that the persons that they serve. So we usually identify community health workers as their natural leaders. So they're people who are actively engaged as volunteers in the community, and they're identified and then brought into kind of a defined role, not necessarily formal or informal, but a defined role where they're actually doing work that they've been trained to do, right? So they get recruited. They're recruited because they have a special knowledge of their community. They have the social capital that some organization, entity, clinic wants to capitalize on so that they can reach that community. And so my work evolved from this process of identifying these women and then bringing a program to them, all packaged and pretty, where we said, we're going to work on this issue, and here is the program, and I'm going to train you to implement this program. And they were great. They loved it, that sort of thing. But over time, my approach to working with community health workers has changed so that now I engage them more from the conceptualization process. So they work with me to conduct needs assessments, prioritize issues, identify strategies, develop the curriculum, implement it, evaluate it. So this process then engages them kind of from the conceptualization stage. It also provides more capacity building, right? So they become familiar with the process that we use in public health, that identifying, assessing issues and developing strategies and testing them. And so it's kind of more aligned with a community health development approach and community organizing, and that we focus on assets, right? So we come in and try to identify what the community has, not what they're lacking, making sure that it's culturally and linguistically appropriate and sustainable approaches that they can afford and that can last after the researcher leaves. Now, some of the challenges I think that we've experienced with this population or in working with this community. So I came to care work primarily because I was concerned about the caregiver. Like I was concerned about the health and wellness of the promotoras I was working with. They work super hard. They're committed to their community. They're always going above and beyond. So if they're a 15-hour week worker, they're working 30 or 40 hours. Communities calling them at night on their personal cell phones. If they're working, say, on a diabetes prevention program, but if a woman has an issue with domestic violence or immigration, or they're there to help them, right? So we have some challenges in terms of kind of defining the boundaries, right? And so this is something I experienced where they get burned out because they work a lot more and it's unrecognized work, right? So they're only compensated for the work that they do that's related to the specific program, and all this other kind of informal labor isn't really acknowledged, but they feel very committed to their communities and want to do this work. And so we found that many of them were very stressed out, and it was impacting their mental and emotional health, primarily because of work overload and because they couldn't meet the needs of their community. So recently with COVID, we conducted a survey. We collaborated with the Migrant Clinicians Network and the National Coalition for Farm Workers' Health. And we wanted to conduct a survey of the impacts of COVID on the health and well-being of healthcare workers who serve these vulnerable populations. These two organizations serve immigrants, refugees, homeless, seasonal, and migrant farm workers. And so when we received the results of the survey, we had about 400 participants. 86% were women. So most of this workforce was women. 74% were Latino. 47% were community health workers. That's what they identified their job to be. And when we asked about their health, 32% felt that they were not getting enough sleep or inadequate sleep. 15% said that their mental health was fair or poor. 47%, almost half, were experiencing nervousness, anxiety. And this is during COVID specifically. They had fears of bringing the virus home to their families. They felt like they were working more hours. And they also talked about the inability to connect to patients with services and not being to follow up with patients who had specific needs. So all these things were putting additional stress. So not only did they have the job-related stress, they also had the personal-related stress. And also 30% reported that they had been treated with less courtesy and respect than other people. We asked them questions about experiences of discrimination as well.
Deborah,
yes?
I'm so sorry to interrupt you. We're coming up on 10 minutes right now, so I'll give you just a few more moments to wrap it up.
Sure. So, so basically, this is kind of where I'm coming from in terms of care work is concerned for the care worker and how we can, support them in the work that they do. And so I'll leave it at that.
Thank you so much, Deborah.
Sure.
Our next presenter is Lilla Pivnivk, a PhD candidate in sociology at the University of Texas at Austin.
Hi, everybody. Thank you so much for having me here today. I'm really excited to be going after Deborah, actually, because she set up my portion of the talk very well. Just to start, so I'm a PhD student in the sociology department, as is Vrinda, so we're classmates. I am a former teacher, so I taught second grade and I taught kindergarten for several years before coming to graduate school and in the sociology program. So I came into graduate school studying early childhood education because that's where my background is, but I quickly realized that there wasn't a lot of focus on teachers themselves. So like Deborah was saying, I became more interested in the health of the caregivers and their experiences on the job. Specifically, I'm really interested in how occupational characteristics of care work get under the skin. That's kind of what we say in sociology to influence the health and well-being of the care workforce. So although I was a teacher and that was kind of my initial interest, I quickly realized that the care workforce is huge. The care workforce is diverse. It spans multiple sectors. It's not just education. It's also healthcare. It's also social service sector. So it's huge and it's multifaceted. And those folks kind of, they're part of a group, which is care work. So I just kind of wanted to talk about that and segue into that, given what Deborah was saying. So one of the questions that was asked or in the prompt that we were given is, what are the forms of care work that you see in your work? So a lot of the literature in care work in sociology, there isn't a clear definition of what exactly care work is for a lot of reasons. A lot of things can be considered care work. I'm particularly interested in professional care work. So I'm specifically interested in teachers, nurses, and social workers, but generally anyone who's in a caring occupation. That's kind of where I live with my research. And so in my research, I define care work occupations as occupations that provide face-to-face services in the context of an interpersonal relationship that helps people develop and improve aspects of their lives that they care about and value. And again, as I mentioned, these include healthcare occupations, social service occupations, and education occupations. Although happy to talk about this in the Q&A, who thinks other occupations should be part of this bigger conversation of care work. So again, in the sociological literature, there are folks who've kind of posited what is the role of the care worker? What does the care worker actually do? And basically, this is part of my dissertation research, is really putting together these comprehensive definitions of what professional care work is. And so although most occupations, regardless of what you do, have some level of care work occupations are those that are explicitly tasked with paying attention to the needs of others, taking responsibility for meeting those needs in some way, engaging in the hands-on tasks of care, and then also providing services in the context of a relationship. So again, there's this idea of compassion that is required in your job. There's this idea of direct service provision. There's this idea that you're not just providing a direct service, but you're doing it within the context of a relationship with your client, your patient, or your student. And then there's this idea of professional responsibility. So I break that down in my research into two parts. One is therapeutic responsibility, so taking the responsibility of teaching, healing, and helping. But there's this other aspect of care work that often it underlies like everything that care workers do. It's this idea of ethical responsibility. And so ethical responsibility is the idea or the commitment to acting in the best interest of your care recipients. So putting the needs of the care recipient above, but also putting down, making sure that decisions are made in their best interest. So there's a legal component of this. There's, one could argue, like a moral component. It's a really interesting point that I'm going to be talking more about in the next few minutes. But and just a few other things before I talk more about ethical responsibility, which is really my bread and butter in when I talk about care work. But care workers are also, and Vrinda also mentioned this, and Deborah, that they're the workforce is predominantly women. the workforce is also highly feminized in terms of the tasks. So we're doing a lot of taking care of. So a lot of tasks that have historically been relegated to women in different societies. Care work occupations are also low paid. They're compared to all other occupations at each level of educational attainment. Caring occupations compared to non-caring occupations are paid less. So there is that devaluation piece as well that delineates or kind of separates care work from other fields. There's also this idea of high intrinsic motivation. So this is really high, this is meaningful work. So a lot of people go into this work despite a lot of its drawbacks because it speaks to them on a different level, on not extrinsic. Like you might hear care workers, I don't do it for the money, I do it because I love what I do. This idea of highly intrinsic motivation is something that really is a big theme in the care work, the professional care work sector. So what's so interesting about care work, and the big thing that I'm studying and seeing, is that care workers have higher job satisfaction than non-care workers. This is a job satisfaction paradox, I guess you could call it, and it's documented not just in the United States, but across Europe as well. But at the same time, although these are highly satisfying occupations, care workers have some of the highest levels of burnout and turnover compared to similarly educated occupations. So I know, at least from my own experience as a teacher, 5 years, if you can make it past 5 years, you're golden. But if you're in that first 5 years of teaching, there's a really high likelihood that you won't continue on as a teacher. And a lot of that is due to burnout. So I also find in my research an inflammatory burden. So I find that the occupational requirements of care work are influencing stress processes in the body that have consequences for later life health. So that chronic stressors in your body, dysregulation of different systems. So that's evident even in early career care workers. So even in people who are just starting out their careers. So the next question was kind of, what are the barriers to effective care? Okay, so I'm really interested in this paradox, really job satisfying, but really high turnover and burnout. And so I was really interested in this idea of ethical responsibility, because in my work, that inflammatory burden that I was just talking about, as well as that job satisfaction advantage between care workers and non-care workers, was explained by the level of ethical responsibility people have on the job. It wasn't explained by compassion. It wasn't explained by direct service provision, although I thought it might be. Ethical responsibility was really the driver here in both driving up inflammation in the body and also driving up job satisfaction. So in the last paper that I'm actually writing right now for my dissertation, I interviewed 41 care workers across 3 very large caring fields, so nurses, teachers, and social workers. And the reason that I picked them is not only that they're some of the largest care working occupations that there are, but they are also similarly educated, because oftentimes education really factors into job satisfaction and inflammation and who's bearing the brunt of some of the negative aspects of care work. So I was really interested in having kind of across similar levels of education, the experiences. And I started collecting this data in the summer, or I had been planning on collecting it prior to COVID, but then COVID hit. And I had this really exciting opportunity to look at ethical responsibility and how it's experienced by people in these occupations, both prior to and during COVID, and how they see it as affecting their health. Do they see it as influencing their mental health and their physical health? And so I'm trying to make sure that I'm staying on time here. But some of the big themes that I really find in my work about ethical responsibility is that people really enjoy this aspect of their work. They enjoy being able to act in the best interest of those in their care. However, having power and being able to make decisions, that's in theory. It's in theory, but what does that actually look like in practice? So in my work, I find that having power is wonderful, but oftentimes caregivers or care workers feel very powerless against the systems that are telling them what they can or can't do, mandates that are coming down from the state level, the national level, from everywhere. I also find that care workers cite strong beliefs, like I believe this is the right thing to do, this is my training. I think that these things matter. But they're actively having to go against what they believe oftentimes in terms of, again, these things that are coming down from the state or family wishes and things like that. And that can put a lot of strain on care workers. And then last, care workers are expected to make decisions, really heavy decisions, pretty often, constantly. And that contributes to decision fatigue, where people are experiencing, they're not able to recuperate from the things that they've experienced on the job. They have to go from one to the next. And COVID has magnified that situation in terms of like the decisions, the heavy decisions, and having to make them constantly. So the last question that I think is really important and I'm really excited about is what I think it might take to change these structures to promote effective caring, because a lot of these care workers are saying, I can't do my job. I can't because of the stress and pressure that I'm under, the ethical responsibility. I need help. I need resources to be able to make these decisions. So in my research,
Lilla, I'm
yes.
so sorry to interrupt you. We are over 10 minutes at this point.
If you
want to take a couple of minutes to wrap it up.
I'm sorry, guys. So employee assistance programs, interdisciplinary team decision-making to spread out decision-making, and also establishing codes of ethics, not just in one field, but across different fields, so that people, when they're not sure what the decisions are, they can look to that codified system. So I'm sorry, very excited about this stuff. Looking forward to talking about it with anyone who wants to talk about it.
Thank you, Lilla. 10 minutes can go by alarmingly quickly. Our next speaker is Gabriela Torres, who is a community organizer at Communities of Color United for Racial Justice.
Thanks so much. Good afternoon, everyone. My name is Gabriela Torres, and my pronouns are ella, she, her, hers. I'm a community organizer with CCU, and Ashleigh is my coworker who went first a little bit earlier. Today I'm speaking and presenting to you from Sana, Tonkawa, and Coahuiltecan Native Territory that is now known as Austin, Texas. And for those who are not able to see me, I'm a Mexican light-skinned woman. I have black hair. I'm wearing golden hoop earrings, and there's a screen behind me that reads, "Safety begins with community," and I'm dressed in a purple top today. And so I want to thank first the organizers of this space, and I'm just really excited to be hearing from everybody and having this conversation with everyone today. And I also want to begin by acknowledging that, you know, my voice today doesn't stand alone, and besides it are the families and the communities with which we organize with as a collective. These are the same families and communities that guide our steps and our actions. And so, you know, when I think about care, there is a quote from Audre Lorde in Burst of Light, I believe, that reads, "Caring for myself is not self-indulgence, it's self-preservation, and that is an act of political warfare." And so in the last 4 to 5 years, we've seen a really big push for what we know as self-care, but often, you know, this notion, as others have and will probably continue to mention, is one that's focused on the individual. And so I want to invite us to think about what collective care means, as opposed to just caring for oneself. And I also want to shed light on how hard that is, or sometimes it's not at all possible for some folks, community members, entire communities and families, because, you know, we can't talk about any kind of care without acknowledging and analyzing, excuse me, the global racial, colonial, capitalist system. Radical care can't be separated from systemic inequality and power structures that this same system cultivates. And these things make it difficult for things like self-care to be accessible or even thought about. And, you know, this is a case that we see in our daily work with those whom we organize with and are part of our local community. And so at CCU, we are made up of and organized with folks and communities that are most impacted by systemic inequality, power structures, and different kinds of violence. Most of our members are refugees from Congo, Cameroon, Black folks and families who are originally born and raised here in Austin, many of whom are currently being displaced from their homes and apartments where they have lived, their entire lives, as well as Latinx folks, the majority migrants from Mexico and Central America, folks from the LGBTQIA plus community, and most of these people are single mothers or elders who are caring for their grandchildren or are folks who are pregnant. And the reality is that because of things such as a lack of access to healthcare, to education, to food and housing, so very basic things, the thought of self-care or just care in general is something folks don't have the privilege of thinking about. And we've realized that we've had to take care of each other and show up for one another. And we've done this, and it's been possible by collective action, but not just with those who we are in the same social situations or positions, but across different races, ethnicities, classes, genders, and others who are, generally and mostly impacted and affected by exploitation, displacement, repression, disdain. And this process requires a lot of work, and it often happens quietly, and it's almost always, fully unpaid. And so over a year ago, around the time of the city shutdowns in March of 2020, CCU created a mutual aid network for folks to receive cash and food assistance. We named this our Racial and Economic Solidarity Network, or RESN for short, RESN, that focused on supporting those that have less access to information and resources, folks who have little or no internet access at all and are most vulnerable to things like unemployment or loss of housing here locally in Austin. When I think about radical care, we had to ask ourselves how to mutually support one another, especially for folks who often did not qualify for other mutual aid projects. And then we built a network with our own connections as an organization, but other local organizers and their networks as well. And so today, we're happy to say, although we wish things were different, but this mutual aid network we're still operating, and we have been distributing cash and food support to folks in our community every single month since the beginning of when we started in March of last year, so a little over a year. In the month after the winter storm hit, over 3,000 of the funds that were raised supported over 100 adults, 100 children, and we had over 44 deliveries in groceries and other necessities. And this isn't counting the cash assistance at all. It's just the food and groceries. And so this all happened when our community did not receive aid or support from the city or state in the middle of a natural disaster. So again, who's showing up? We're showing up for each other. We're also actively involved in the Reimagining Public Safety Task Force. And for those of you that are listening to things that perhaps maybe this is the first time that you're hearing them, I'll definitely drop a link after I'm done speaking. But the Reimagining Public Safety Task Force is a process that is made up of many local organizers and organizations that are looking to move millions of dollars from the Austin Police Department to instead invest in our community. And this process was born and pushed for by community members amidst the continuous brutalization, criminalization, and threats to Black and Brown community members by the police, both locally and nationally. About a year ago, a little less than a year ago, I think. And so this task force dedicated its efforts to make recommendations to the city of Austin on how we could utilize public money to keep our communities safe. And so, for example, in 2020, 40% of the city budget was given to APD, while only 7.9 was used for public housing and less than 1% of that same budget for housing, for example. This process was part of the larger community because we literally had to reimagine and ask ourselves what safety can look like together and envision a world where we need to keep us safe and healthy, and think creatively about how this money goes into the community to improve access to resources and support. And since we're in the middle of a global pandemic, we had to adapt and change the way that we communicate and build together with the community. This lengthened, or often lengthened, our conversations and planning, but we believed, and we still believe, that without that direct voice of the people, it would have been, an appropriation of experiences. And so, for example, one of the first projects that we did in the framework of this process was to gather direct testimonies from community members. And we did a video that intended to shed light on what the people in Austin need to feel safe. And so we asked very specific questions, things like, what would you change in your city to improve your life and the lives of your family members? What would you change in your neighborhood? What kind of support they needed or they need in their community to feel safe? And then just about their daily stresses. And it sheds light to their realities. And so these are just, some of the small ways that I feel that radical work is present in our path and our commitment in our work. We cannot count on the systems that exist to support our communities. And we often find that we end up taking care of each other. This is why we work and build together. We do so collectively. We don't have another choice. It's important and essential to invite folks to organize alongside those communities that not only that we pertain to, but those that are around us, but especially those that are most directly impacted every day. These are the folks that should be here. These are the folks that we should be listening to in order to see what needs to change and how we can, really show up for one another. So thank you.
Thank you, Gabriela, for your incredibly important work. Our final speaker, last but absolutely not least, is Yolanda White, who serves on the executive board of the Texas State Employees Union. And Yolanda, I think you might be muted.
There, thank you. Thank you again to the group for the invitation, to my panelists. Thank you for the insight. That was some great insight on what radical care is. I want to speak personally because I have spent 17 and a half years of my life as a direct care provider for the state of Texas, taking care of individuals who we deem total care, who need total care provided, physically, mentally, intellectually, just across the board. The people I care for on a daily basis can't do anything for themselves. And really, all of you ladies touched on the rewarding aspect of my job, and yet the physical demanding part of my job on my body. So I want to speak about, I want to talk about radical care from the day that we are born into this world. A mother cares for her child. That is radical care. We are cared for, nurtured, educated. A mother is all of those things. She's a teacher, she's a care provider, she's a nurse without being a nurse, without being certified as a nurse. She's all of those things. And then you ladies touched on shelter, community, social services. There's so many aspects of care. The spectrum runs so far and wide. I'm coming from my work, which is a personal care provider, direct care provider. And our question was, what are the forms of caring that you see in your work? Again, we provide primary care, specialty care, long-term care, mental health care, urgent care at times, emergency care at times, specialty care. Also, I work with a lot of women. There are men there, but the majority of us are women who are educated. We are in a very small town, and there are not a lot of opportunities here. So a lot of the women that are people in general that I work with, it's either our job or Walmart. And unfortunately, when we talk about some of the barriers of what we do, it would be funding cuts from our state and local governments, vital funding that is required for us to perform our duties. It's a lack of respect for care work. Care work is devalued in this country and abroad. I think we don't look at it as the necessity that it is, the importance that it is. Like I said, from the time we are born into this world, there's so much nurture and care for us. We send that person on to early childhood education, which I am also certified in, and they're being again nurtured and taught, and then we send them on to school where our teachers again nurture and care for. So care is vital. Care is radical in itself. It is something that the pandemic has put on the forefront in a way that it wasn't before. I think we look at it as essential. We have heard that term essential workers, and we sure classify ourselves as essential workers. Unfortunately, our pay is low, our hours are long, our work is physically demanding at times. Like I said, I have 17 and a half years of service, and I have the scars to go along with those years of service. But it's also rewarding. As Leah was saying, it is, I guess, a double-edged sword. It's like somebody has to do it. Why not me? Why not us? And as Ashleigh was saying, you know, we have to change in this country the way we look at care being provided. Black women are treated differently across, not only Black women, Black and brown women, but we experience that discrimination anytime that we go to a doctor or try to get any aspect of care provided. It's always, they believe we have an ulterior motive. And I think we just have to change the way we view care in this country, and we have to start valuing each other. We have to start putting funding behind our community services, our social services, our teachers, for Christ's sake, who are very vital in our children's lives and are underpaid and underappreciated. It just goes across the spectrum. And one of the other questions was, what do we think it might take to change the structure that prevents effective caring? I think this country needs a paradigm shift. The way we look at care, the way we fund our care. I think we see care as what am I trying to say? Care is the foundation to every life. So we have to start treating it that way. We have the people who, like our legislators here, we're going on our 9th year. They just wrapped up a session, and we were not given a raise. So that's 9 years without a raise. And well, there are people who can go work at gas stations and serve fast food and make way better money than we make. We have to start valuing care in this, not only our country, but abroad, across the whole spectrum. It's vital. Care is vital, and we are nowhere and nothing without it. Every aspect of our life, someone is providing care. And you ladies all just touched on that, whether it's the community service, whether it's teaching, our shelters, our hospitals, your home mothers, speaking on unpaid care, underappreciated care. It's just, you know, we always talk about mothers not being valued or not getting the recognition for the care they provide. And we have fathers too. We don't want to leave them out. They are also care providers. Men are also care providers, but the majority of us are women in this field. And we just have to rethink and reimagine the way that care, the emphasis we put on care in this country, because we, like I said before, care is essential. It is an essential part of our life. From the moment we enter this world, it is an essential part of our life. Someone is caring for us, nurturing us, guiding us, providing for us, protecting us. So it's so many aspects to care. And the panelists, you guys you gave me some talking points to touch on. Like I said, the spectrum runs so wide as to care, how many, I mean, it's stretched so far and wide. I don't think we can possibly cover it all. But again, it's devalued, and we have to reimagine. We have to find ways to turn that around through organizing, which I'm glad to see our new administration supporting organizing, because it is very vital to what we all do in this fight for equality and better resources and better care. And you know, over the years, I've seen funding cost be cut, and I see on a daily basis even the equipment that is needed for us to do our job, or for our individuals for their daily lives to function. We are piecing together equipment, something I've never seen happen. And as the years go by, it seems to be getting worse and worse. So I wish our legislators, a lot of times they are the men who make decisions over women and our choices. And I wish that somehow, some way, we can elect a group of people who understand the importance of what care is in this, not globally and here at home. So let's see, we also were asked.
Yolanda, I hate to say this, but we're coming just up on 10 minutes right now. So if you'd like to give us any last thoughts.
Yes, I just want to emphasize that what all the other panelists touched on was very vital. And I thank you for that, for sharing that. And I thank you for my time.
Thank you, Yolanda, for speaking so many truths at the end of our roundtable. As a way to segue into our Q&A, for which I invite all of our participants and our audience members to think about what questions you might have. I'll just take a couple of minutes to speak on my own work around radical care, which centered in a 2020 special issue of Social Text, an academic journal, which I co-edited with my friend and collaborator, Tamara Neese. And in it, we offered an idea of radical care as a set of vital but underappreciated strategies for enduring precarious worlds. And by centering our analysis of care as a core element of political movements, rather than something that is supplemental to or beside them, we wanted to trouble the way that care is sometimes left underexamined as an affective, often feminized, and thus undervalued form of labor. Because radical care, we argue, is inseparable from systemic inequality and power structures, it can then be used to coerce subjects into new forms of surveillance and unpaid labor, to make up for institutional neglect, and to even position some groups against others, determining who is worthy of care and who is not. We looked in our essay at the differences, tensions, and contemporary intersections between community care and increasingly commodified forms of self-care. What forms of care, we wondered, serves the needs of hyper-productivity that like capitalism demands, and what forms of care resist it. As my colleague in Black Studies, Pavitra Vasudevan, wrote in her recently published piece on the intimacies of race and waste, quote, "Racial capitalism preys upon the very relations of care that people depend when their lives are devalued." In other words, radical care is both a response to and also a feature of systemic inequality, which relies upon forms of care to fill in and maintain the chasm between privilege and structural disadvantage. Black feminist and Indigenous political traditions have already done so much to chart out the genealogies and the futures of radical care. From Audre Lorde's frequently quoted declaration that Gabriela brought into the room for us today, to the Black Panther Party's free breakfast program, to the establishment of urban Indigenous health clinics in the wake of the termination policies of the late 1960s. Radical care then is not new by any stretch of the imagination. And so I think it's worth considering how and why we are talking about it again so urgently right now. What, I wonder, calls us back to these radical traditions? How are they taken up during our current crises of care? And how we can honor those genealogies through our current work. We had a question already come into the Q&A that both Anne and Lilla prompted in the chat, which is directed to Yolanda, if you're okay opening up the session. And I can see that my camera is frozen tragically, but I hope you can still all hear my words. And the questions are to Yolanda to talk about first what you feel the role of the unions are in protecting care workers, especially in Texas, and a little bit more about why you are involved in a labor union.
Can you hear me?
Yes.
Okay. I'm involved in our labor union. I've been active for 16 years now. I assist in organizing my workplace, as well as phone banking to help organize across the state and help elect persons who will fight and stand for our issues. One of the barriers is pay. We're state workers, but our pay is lousy. And like I was mentioning before, we just ended another legislative session where they didn't see fit to give us a raise. So one of the things that we organize and why I'm involved is our pay, fairness on the job, equality and justice on the job. We organize for our pensions. We just had a pension fight, which, as you all know, did not end well. Hopefully that will somehow turn around. We organize for conditions for, like I said, pay, justice on the job, our pension, our healthcare costs. So it's vital. Being a part of an organization that helps to fight for things that should be a basic requirement when you are on the job, things you shouldn't have to, on top of doing your daily duties, fight for. That's where the union comes in and help to strengthen numbers. So we always stress their strength in numbers. And we do all we can to organize as many as we can here in Texas. And we belong to CWA, so we have a broader union other than just TSCU here. But basically, we organize for our pay. That's everybody's number one issue. If you ask, it's pay.
Thank you, Yolanda, for all of your work. I am fielding questions as they come in the chat. I would also like to welcome audience members to turn on their cameras to engage in conversation, even though mine is currently off until my internet resolves whatever issues it's having. And in order to give you all a moment to think about what you might like to know, including the panelists who might want to pose questions to fellow panelists, one of the things that really struck me across these talks is that so much of the way that care work gets treated by the state is kind of premised upon this presumed tolerance for stress that seems to be extremely gendered. And the tensions between the essential, like the inherent tensions of the essential worker that I think have become brought to the forefront during the COVID-19 pandemic, which is that the essential worker is simultaneously essential and dispensable and replaceable, right? And so what we see is that the work is deemed essential, but the worker is not valued. And I would be curious to hear from our fellow panelists about how that might align or articulate with your own observations.
I think something that I've observed in my work is the role of hierarchies within care delivery and who's bearing the brunt of being disposable. So like, for example, in a healthcare setting, a lot of my nurses that I talk about doctors not wanting to interact with patients or having more options to do telemedicine, while nurses are front and center. They have to do it, and they often say, hey, I'm tribute. Like, you're treating me like I'm tribute, or treating me like a lamb. Why am I doing it when other people who are just should similarly be essential workers and have essential worker status? Why are they getting a pass sometimes? So I see that in healthcare. I see that in teaching as well. So yeah, so I think that that's also an interesting conversation of power differentials, hierarchies, and how they operate within the caregiving space, even amongst care workers.
Would anybody else want to offer their thoughts or pose a question?
Yeah, thanks, Lilla, for that comment. I was actually, I wanted to respond to something that that Yolanda was saying about unions organizing and protesting for better wages, and connected back to something that Lilla brought up in her presentation, which is that I just find that care, women's care especially, just constantly gets stuck in this like love versus money like framework, right? Like that academics have written about this, like Nancy Fraser, but of course, you know, from all the union organizing, from all the protests, that people want to be, I mean, just because they like their job doesn't mean they don't want to be paid well for that job. But there's this constant pitting of one against the other, which only somehow seems to happen for this very feminized occupation, where, even within care work, we have to recognize that care work is driving actually polarization in job market polarization in the US, because white professional women, tend to dominate nursing, where wages are much better, whereas Black and brown women tend to dominate, a lot of the backroom kind of work of cleaning and cooking and all of that, where wages are very poor. So, even care work is not it doesn't look the same for everyone who does it. There's a larger care penalty, yes, when you compare it with other occupations, but even within care work, there is polarization, and we have to recognize that polarization. And I find this, I feel like this conversation around intrinsic versus extrinsic motivations is simply empirically not true, but it's something that is like a vestige of traditional behaviorist, economists who talk like this. Like, if you have extrinsic motivations, it'll crowd out intrinsic motivations. You don't see that in any other profession. You would not make that argument. And it simply is not borne out by the ways in which, as if, well-paid and well-fed workers are not going to do their jobs. Somehow it's such a bizarre idea, but you see it again and again with a highly gendered, classed, and racialized workforce. And I don't think that's a coincidence. So that's just one comment that I wanted to make, and maybe also just take this occasion to pose a question to Deborah, actually, because of course, Deborah, with your work on community health workers, it sort of has the most resonance with me. And I was curious, like, you've seen so much, you've seen the workforce in so many different settings, and you've seen so many different pay arrangements, right? Like with incentives, voluntary salaries, whatever. Do you see trade-offs with more formalization of the role and, with salaries and things like that? Or do you not see, any sort of trade-off with more formalization? What's been your experience?
Yeah, I mean, there's some kind of discussion about kind of the formalization, the professionalization of these workers, because then that takes them out of the community, right, and into the work setting. And so, I mean, I think it has, some benefits, because there's more, legitimacy, there's a little bit more pay, there's more consistency, even though it's inconsistent, right? Because a lot of this work is part-time, periodic, or episodic. But it's still is more than others, right? Like you're saying, it's kind of hierarchical in that way. But you do lose something, because then the people are really pulled out of their core community, right? So then their kind of service area becomes a bit broader. And so their expertise becomes more generalized to like a broader community, right? It's not really that intimate community knowledge anymore. It's much more kind of like this generalization of expertise, I would say. And, one of the things that triggered me with what Gabriela was talking about in terms of engaging the community. So, health is focused a lot on individuals, right? And so a lot of community health work is reaching out to individuals. And so what we've been trying to focus on now is, trying to expose community health workers to see social determinants of health, and to see and understand, structural inequalities. And so having them kind of look, understand, and examine, so that they can begin to engage in kind of small social change efforts. So for example, we do things like making sure that there's shade in parks, or, water, or functioning bathrooms. And so as they get more confidence, and they can maybe work on broader issues as well. So I think we also try to shift the work that they do away from this individualized care to more
no, thank you. No, thank you.
Instruction. Yeah. So Yeah, and I think in terms of the pay, it really depends on the organization and what they have and what they want from the expectations they have from the community health worker.
Thank you, Deborah. So we've got about, I think, 10 more minutes of official panel time, which means that we've got enough time for maybe 2 or 3 more questions, which I'm happy to take in the chat, or if you'd like to unmute yourself and give it verbally.
I'm really appreciating this conversation, this discussion. Thank you to all the panelists for coming together. I wanted to follow up on just what you were talking about, Deborah, right? In our conversation from last Thursday, one of the things that there's currently this, in the U.S. at least, push with the Biden-Harris plan around funding, 100,000 community health workers across the country, which is fantastic and insufficient. But there's a lot of health systems, hospital systems that are not interested in restructuring their approach to care, but are interested in bringing in community health workers to assimilate them into the current structures that exist, right? So on one hand, I see this tremendous hope and optimism that frontline public health workers coming from the communities that they will continue to work in are being engaged within the health system, and there's a possibility for shifting the culture within health systems, and maybe even a possibility for organizing healthcare workers with community health workers sort of leading those charges. There's possibilities there, but I also know that the way that the healthcare system is structured, as Ashleigh put forward really clearly, right, it's not a care system. It's a capitalist system, right, to drive for profit within this country, certainly. So I wanted to ask, what are the possibilities for rearranging or thinking about organizing, especially amongst community health workers, where there's currently financing on the table for that space, or organizing, sort of labor organizing amongst community health workers. And then also the second part following up on that, I think of community health workers as community organizers, right? Community organizers who are really advocating for structural change within the community, policy change, trying to bring together not just individuals, but families and the communities to push for change in power structure. And so, an open question to everybody is sort of where are the possibilities for that, and then the third thing I'll throw out there, and feel free anybody to jump in on this, but there is so little hope in my mind in some ways around what is changing with certainly paid and also unpaid care work, right? The around the world and in the United States, things are as gendered, if not more gendered, as racialized, if not more racialized, and the pay is continuing to sort of go down. Where is the sort of, how do you think about the positive vision in terms of organizing sort of radical care?
I was thinking, do community health workers, how much control are they going to have over the work and defining the work that they do, right? So is spending time at community meetings, networking, doing this kind of organizing work part of the job description, right? Or is it, making so many appointments, making sure people's, monitoring their diabetes or whatever this thing that they can count and see. And so if they don't have, I think, some of this agency and autonomy in their work, I feel like it's not going to kind of get the outcomes that we want, because many of the community health workers also have their own social networks, right? They rely on each other to make things happen. And so you kind of have to be outside doing that work. You can't be inside the system.
I'll welcome any other responses to Snehal's question. Well, I think that we have time for maybe one more question. And Lewis in the chat has another one directed towards Yolanda. So perhaps I'll bring that to the table now, which I'll read if it's okay. Ann Lewis is asking what went on inside Texas State supported living centers where Yolanda works in terms of protecting workers and residents against COVID.
Can you hear me?
Yes.
Okay. Precautions were taken. We had a lot of, in the beginning, a lot of our supplies, which was our hand sanitizers, our disinfectant wipes and sprays, and different things like that were all confiscated for the fear of employees walking out the door with, which upset a lot of us because we were on a call with the commissioner and we talked about the hand sanitizers, which were the individual bottles. And we were like, if an employee walks off with one or two of those compared to us being able to have access to those items, you know, we felt like it was more vital for us to be able to have access to those items. But some of the things that were implemented immediately, and I think this was pretty much across the state of Texas, were temperature checks at the gate. We were provided PPE, which included masks and gowns, hair nets, shoe coverings. We were all fitted for N95 masks, but then again, we had some controversy there with you wear your mask and then you put that mask in a brown paper sack for 3 days. You have to get a new mask. And the issue started becoming when you had to get a new mask. So if you were sent to a COVID unit and you were given 2 masks, that would mean that you would have to, if you were sent there a week, you would need at least 3 or 4 masks to get through the week before you could re-wear that first mask. So there were some issues with that, but we were COVID testing at one point 3 times per week. It went to 2 times, and now we're doing it monthly at this point. We have begun to get some of our disinfectant and our wipes back. We had nurses having to bring in their own sanitizer wipes to disinfect equipment. You know, when they take vitals in between the individuals, they had to wipe those things down. We were on a call with the commissioner and made him aware of some of these things, and you know, they were not happy. The center was not happy, but things got, the issue was paid to the committee right off that we should have been reserved, but if a pay that we get to come through our letter hearing and value don't value what we do. So that didn't happen. I have a lot of coworkers right now that are unhappy because we were not given hazardous duty pay, but you have unemployment people getting this plus up, and they're very upset about that. And I had a conversation just the other day, and I said, well, I wouldn't have to worry about and waiting for unemployment and going through that whole ordeal. I said, I'm not upset with them because they were provided a plus up. I'm grateful that I did not lose my job, even though, yes, they feel slighted, and in a way I do too, but I don't blame the unemployed employees or people that faced unemployment for that. But they did take precautions. Things are getting better. We have very few COVID cases. We did have a death right off the top of the pandemic, an administrator. We've had I myself have actually caught COVID, so I was home for a while. We have very few cases. We still have some cases, but they're few. They're not like they were in the beginning. So the precautions that they have put in place seem to be working.
I just wanted to say the reason I asked the question is this was a big union demand, really coming out of Denton State Supported Living Center. And when Yolanda talks about talking to the commissioner and so forth, that wasn't as an individual, that was a union demand. So I think this is another way that unions play a very big part in changing the way that care is structured for not only the people that work in the facility, but also for the people that live there. And I actually think that what happened in Denton particularly, maybe not where you work, but in Denton, was absolutely a scandal. So I just wanted to say that.
Thank you for these really important points. Of course. Sorry, Yolanda, did you have more thoughts you'd like to add?
I was just going to add on to that what Ann saying, because we also spoke with our local representative here. Again, it was a union issue and it centered around what did happen in Denton. And then we had a big article wrote up in our paper about some issues here. One of our employees went to the paper. And so when I spoke with our representative, which was my organizer and our legislative director, changes were made immediately. So that, again, like Ann is saying, unions are very vital. I wish more people understood the importance and would take part and sign up to become a part of a union, because there are power in numbers. We get things done, but we could do so much more if people would just realize the power that a union has and what all it actually does for justice, like we were saying earlier on the job. Thank you for that question, Ann.
Thank you. So we're coming up on the end of the formal portion of this roundtable. I would like to take a moment to just sincerely thank and express my gratitude to all of our panelists today for your incredible work, your important work, and for sharing it with us so generously here. I'm going to turn the floor over to Snehal, who will keep the room open for non-moderated conversation.
Yeah. I will, I think we have another 30 minutes or so. And so, I think our hope was to have just some conversation and I'll kind of leave it at that, see where our conversation goes.
In the chat, Snehal, I kind of was thinking more about the question that you asked, right? About organizing among community health workers. And there are like regional associations, right? Like I know the one in San Antonio, there's one locally. I don't know how much these regional associations connect across states and the nation. But most of the work that they do, from my experience, is networking, sharing knowledge and resources, but not necessarily organizing like other professional associations do, right? Like the American Medical Association, or they come out with position statements, or they publicly support, the causes of other people or organizations that are aligned with them. And so I don't know, if they would come together as a group, right, to advocate for how the job should be defined, how they should be compensated, and all these sorts of things. They're kind of highly variable. But, Texas is a non-union state, right? So maybe in California, they can try it.
and they're very anti-union here.
I know with our, here locally in really trying to bring together community health workers that are working in many different spaces and really developing a network where community health workers can organize, and share within that network and also build political power. But as you said, there's less of the it's harder to formally organize in Texas. That being said, the National Association of Community Health Workers in El Paso, the C3 or 3C group, and I know they're pushing forward sort of standards of work, and which is different from organizing as care workers or as community health workers, and so.
Thank you all. This was such a great panel. It was wonderful hearing everyone speak. Vrinda, I'm wondering if you could actually share a little bit of what organizing looks like in India with the Ashas. I mean, a different state, an ultra right-wing Hindu fundamentalist state that is deeply Islamophobic, anti-Dalit, anti-women. So what are community workers doing there? Especially given that this is a job that is a state job, not job, whereas I would imagine community healthcare workers are organized slightly differently in the US in terms of workforce.
Yeah, thanks, Shamina, for that question. So Ashas, although Ashas were recruited under a national, so like a federal program, health itself is a state subject in India, which means that states have a lot of freedom to pass their own sort of health laws, and to also pass their own incentives or add incentives to what Ashas are getting from the central government. So that's also why the payout to Ashas varies so significantly by state. So what's happened is the national unions of Asha workers, I think, have not been as successful. They just organized a strike on the 24th of May. It's the unions at the state levels that have really, that have been able to be very united and put a lot of pressure, that have been the most successful in getting their wages raised. So the state where I do my fieldwork, Punjab, has not seen a lot of success, even though it's seen some organizing. One reason is because Punjab has very fragmented Asha unions. Haryana, on the other hand, another state, a neighboring state, has seen the level of organizing where all Asha unions came under one banner and they struck work for 16 days straight. And if Ashas go on strike, basically the health system, it just cannot function to capacity. It can't, just because they've been given so much responsibility that they're helping everyone, do their work. So that saw the Haryana government actually respond and give them like a base salary on top of which they get incentives. So the overall wage went up, even though that fundamental sort of incentive structure they could not change, right? So I think the success has been variable. It's depended entirely on state level efforts, I would say. It's depended on state governments, but mostly on Asha organizing.
So if an Asha is out doing something and something goes wrong, they're not protected by the state in any way.
So
even though they're like a state representative, even though they're not compensated, are they at least, protected?
Yeah. So, with Ashas, there is, what the state has done is the Indian government's kind of made, I think, some overtures to Ashas. They've included them in a health insurance scheme, in a life insurance scheme. But one of the demands of the union actually at this most recent national protest was that The medical compensation and the life insurance schemes under COVID, they seem to exist only on paper, because between April and May, the unions claim that over 80 Ashas have died of COVID, while doing frontline work, and their families have not seen any of the compensation that has been promised by the government. So I think accountability is extremely low, and Ashas are also, I know that with community health workers, the term community sort of, I think sometimes it can disguise a lot also, because communities turn on the community health worker as well, So certainly with COVID, these Ashas are going door to door, and a lot of families they're afraid of the stigma of, being declared COVID positive. They need to work, they can't afford to quarantine. So sometimes Ashas have been abused, assaulted, attacked in these very communities. So it's not, and this is not, I mean, this problem is taking on new dimensions under COVID, but this is not a new problem. In the past, a lot of Dalit, which is, formerly sort of untouchable castes, their settlements, the most in need, you could argue, of health services, have often complained that an upper caste Asha worker will not visit them. She will not go to their homes. So I think that the term community can sometimes conceal a lot of tensions that exist within communities that can be a very big problem for the health worker. And you're absolutely right. Accountability is extremely, extremely low, much lower than it would be for any other worker in the health system.
Nobody's saying anything. So can I re-ask that question about sort of visions for radical caring, like especially for our organizers who are really, who are organizing, right? Which requires just some level of an optimistic lens of possibilities for building better.
I'll take, can you all hear me?
Yes.
Okay. I first want to say that Texas is we do have organizing here. We have a lot of pushback with our legislators, but we have plenty of unions here, not just Texas State Employees Union. There are many unions here in Texas. But I want to speak on community organizing and how vital it is, and just use Georgia as an example of what they were able to accomplish during our last election. And that was all from on the ground, grassroots organizing. And that's where it starts. It starts on the ground. And you just have to, the fight continues. It's never going to stop. And the only way that our jobs are going to be valued, radical care is going to be valued, is to fight through organizing, to organize for better pay, organize for better work conditions. And it's radical. Organizing is also radical. And it's a long-standing fight. You have to be in it for the long haul. But it starts with organizing. And I believe that's a vital. That's I think they go hand in hand. I don't think what I do every day would be possible if I didn't have the union that I have organizing on our behalf, like Ann was saying earlier, to make sure that we got the proper precautions that were put in place. And it took some claws to our legislators and our representatives and our commissioners to make that happen, which shouldn't have been the case, but it was. And that's where the unions do a lot. They do a lot. So I think we don't give them the credit. And it is a long-standing fight. It is a tough battle, but we cannot give up. We cannot give up. So all of you organizers out there that are organizing, don't give up. And as hard as the battle is, it will pay off in the end. We have to stick to it. We just have to stick to it.
I also wanted to, oh, sorry about that. Go ahead.
I was just going to ask you to talk, you or your coworker, about community organizing.
Yeah, absolutely. I mean, I think that, CCU, as CCU, we're an organization that, our members are folks that are directly impacted, or some of them, excuse me, are most directly impacted. And I think that it's so, I'm going to reiterate a little bit about what I said. It's just so important to have these folks kind of lead these kinds of conversations, and also kind of lead when we're talking about what world we need, or what world we envision, where we feel safe, where we have access to the very basic needs, as housing, food, healthcare. I think that these folks are central, right? Give me 1 second, y'all, excuse me. I stopped my video and I didn't mute myself. I'm sorry. Recovering from a really bad cold. But I think that, when we think about radical care, and there's no other option that we have, because, as I mentioned earlier, unfortunately, we can't rely on our city. We can't rely on our government. We can't rely on our state. And so we have to take care of each other. Now, how do we do that when these systems still exist? So everything that I'm hearing now, the abuse that people are living in their workplace and on the streets, the system's still there. And so it's a lot of hard work. It's hard work that entails a lot of engagement on the ground. There's a lot of, we have a lot of conversations with folks that are in the same predicament that we are in. And like Ashleigh talked about earlier, representation and that kind of thing. So obviously seeking those things, but it has to go across the board. There are, with other races, other ethnicities, other religions, other, people with other folks that live in the intersections of oppression, basically. And it's exhausting. It really is. And Snehal said something earlier, sometimes one can feel pretty hopeless. You're like, okay, well, what else do we do? But then, we still have each other, and it doesn't matter, how many, it might be 10 of us or 30 of us or 50 of us. Like, that collective power is so powerful and essential, and we can't do it alone. And I'm just thankful that we do have each other. And I think right now it's about reaching out and being able to engage with others that perhaps do feel like they're alone or are going through really difficult situations just in their day-to-day life. People like Ashleigh who have gone through those experiences, and talking about that real stuff, but also talking about what is not working politically, and talking about the world that we need, right? And so, a lot of the times, folks that are most directly impacted, we don't have time to analyze the system and talk about dismantling it, but we can create networks and solidarity amongst each other to be there when we need it, and continue to push and occupy spaces where our voices are amplified. I mean, for example, the Reimagining Public Safety Task Force is something that, the city of Austin did to kind of check off, the list of good things that they're doing. And we knew that our participation there was, I mean, it was an opportunity that we took to really push for what we're already trying to build and fight for. But that doesn't mean that we're, you know, laying all of our eggs there and betting on that. No, we know that we can't rely on the city. So at the same time, simultaneously, we're still base building, we're still you know, trying to stay connected with one another. During the winter storm, I mean, those of us that had electricity and water or had a stove, we were cooking and sending food out. Those of us who had trucks, like that is what solidarity looks like. And it's not easy. It's tough, and it's, you know, part of me wants to say, like, it sucks that it has to be that way, but until we have what we need, we don't have another choice. And I can't emphasize that enough. And you know, to continue occupying those spaces like we did with the Reimagining Public Safety Task Force. And now we have really good recommendations that we're not going to let go, we're going to push for. But we can't do that without those that are most directly impacted. Otherwise, we co-opt that story, we appropriate it, and it isn't ours. So those folks are always at the front line. If that makes sense. I hope that all makes sense. And I want to invite folks, earlier there was a call to action that Ashleigh kind of was pushing forward. Ashleigh was speaking, and it's talking about really envisioning, you know, that world and thinking about what, you know, for example, what would it look like if we didn't have law enforcement? What would it look like if we invested more money into the people and not into the structures that are not working? On the contrary, the structures that are hurting Black and brown folks, that are hurting a big part of our community. You know, people can't take care of themselves, and it's hard to take care of each other when we do not have the basic things that we need. How can someone take care of themselves if they don't have water or they don't have employment? It's just impossible. And so it's like going to the doctor. You know, we go to the doctor and often we're just treating symptoms, and we're not treating and focusing on the person and their surroundings and how their social situation is going to have a deep and profound impact on their health and their well-being and the way that they manage things from here on out. And so it's a lot more complex than just, you know, focusing on one little thing. There's a lot of aspects that go into it. And I can talk forever, so I will stop now.
I'm curious. So, and maybe Vrinda, maybe you can speak to this. I'm really interested in trying to figure out what's that space between like academia and community organizing, and how can we like marry those fields, or is that just like inherently like is the university like a one of these forces that's harming communities that they're trying to help? And how do we reconcile that or partner effectively to make change?
I can start, but I'm sure others have reflections on this as well. So before graduate school, I used to work with feminist health groups in Delhi. And a lot of these groups were sort of a part of social movements, specifically public health, the autonomous women's movement, and the queer movement in India. And I think that this is I mean, graduate school was a bit of a shock to me, because in India, there's still, and I think in much of the global South, actually, there is the understanding that academia is very political, you know, and it's not divorced at all from activism or community organizing or whatever. In fact, the best academics are some of the most sort of public facing ones. You know, it's understood. It's just, it's a social fact in these places. Whereas here, there's just such a push to sort of professionalize, to sort of get you to be more and more, you know, objective or whatever. And it's, I think we have that problem much more in disciplines like sociology or economics that are trying to constantly be closer to the hard sciences, you know, rather than some other centers like women and gender studies and, you know, the more interdisciplinary places. So somewhere, if we were less insular, I think we wouldn't even think of this as a problem. You know, we would see that in many other spaces and so many other parts of the world, this is not even a question, you know. So I think there's some sort of mental shift that we need to make. But apart from, you know, this broader sort of point, I think, Lilla, like, you know, your work just really, you know, like important findings coming out of large sort of data sets, you know, that are making these connections. I think these are the most digestible by policymakers. So research like yours certainly, you know, should be going directly into policy, and you can start writing about it, whether it's in popular media or in the more policy-oriented sort of academic journals. You can do all of that. I know you're someone who's very keen on like using panels and meetings and conferences to, you know, put all of this forward. I think that apart from that, maybe wherever you are next, right, post grad school life in Austin, like if you connected with some of the networks that might not overlap with those academic meetings and conferences, they might lead you into more spaces where people are interested in your research, but simply aren't sharing, you know, more academic spaces with you. I think that happens all the time. And it is our great mistake and arrogance to assume that, you know, the community of intellectuals is exhausted by academics. It certainly isn't, you know. So if we kind of, I think, make like more of an effort to develop those connections, I think you'll find that so many people are interested in your research. You know, I mean, how can they not be? Like you said, there are so many care workers. They're certainly interested in hearing, you know, about these ideas. So.
And you know, I mean, I'm hoping I understood this, but there is a big gap. There's a gap between, you know, academics and the community, and a lot, you know, I think I'm speaking to the choir here, but a lot of us know that it's a lack of access. Folks from the community who, again, like I'm repeating myself, but who have to worry about surviving, right? Cannot or can't think about, you know, pursuing, you know, quote unquote, higher education or that kind of thing. But as it was said before me, like engaging with different like grassroots, like organizations and community health workers, community organizers, I think is super important to stay connected. I mean, we need both, right? We need it all, but how do we kind of like do this, right? And work together is, I think, a big challenge, and making it accessible, right, to everyone is a really, really big challenge.
Thank you.
I was going to add, you know, I also think that, and Vrinda, you mentioned this, right? In this is changing, or you know, I feel like it's changing in India as well, and moving more towards this U.S. model of academics in some ways. But academics are disincentivized, actively disincentivized, even if they are politically committed towards you know, a certain type of engagement. They are actively disincentivized from deeply engaging in communities, even if those are communities that they work within, and especially within their local communities, right? Like it's not incentivized at the very local level, at the department level, let alone the larger sort of institutional levels. And so I think, that question also kind of comes back to us, right? As folks within the institution, within academics, right? Like, how are we battling that within our own spaces?
Shameless plug for the LRI, but so one of the things that we're trying to do, but it's really, really hard it's an ideal, right? It's something you're striving towards, but always trying to figure out how to do it. And so one is, being committed to the research, not only going into, peer-reviewed professional journals, but trying to get that information into some usable format so that it can be used quickly to inform, local efforts, policy, that sort of thing. So, but it requires a whole infrastructure of people with a different skill set, right, that can develop fact sheets and policy briefs. And now we have to do, Instagram and, and Facebook, and because there's all this social media, right, because that's where the conversations are happening. And so the pace of academia is so slow, and what's happening in the communities happens so quickly, that I feel like we're putting so much effort to trying to do this, but the outputs are just barely coming out. So maybe as we get more capacity and skill, we can do that work. But I think, the pace of the work is very different. Communities work really fast. They mobilize quickly when things happen. And it's very difficult for us to do that in this kind of context. The other thing that we try to do is if there's a specific need from a community organization, we've actually done reports for community organizations. So if they see a problem, we try to see if we can gather some data to kind of demonstrate the evidence that supports that or does not support the problem that they're interested in. So trying to use some of the assets that we have for the benefit of the community as well. But there's not a lot of institutes around that do that kind of work, and it's primarily because it's something that our institute values and wants to do, and so we make it a priority and invest in it. But like I said, it's an ideal because even though I feel like I try to do it every day, the outputs are just not happening as quickly as I'd like.
It's kind of interesting because that question brought us back to radical caring within the academia as well, right? As to what is that potential for us and what does that look like? So thank you, Lilla, for that question. Any last thoughts? Because we're 3 minutes over time, I guess, right, Lilla? Yeah.
I just want to say thank you to each of the women on the panel for sharing all of your insight. It was so important and vital. Ashleigh, I'm sorry that you went through what you went through. Unfortunately, that is what happens, and we have to work on that. That's another issue where we have to fight. We have to always fight for equality in everything we do. For the people that we serve and for ourselves. But I think each and every one of you, I couldn't ask for a better panel to be a part of, and I'm grateful. Thank you.
Thank you, everyone. Please do keep in touch. And yes, thank you for such a productive and generative conversation.